Hi everybody, welcome to my talk today, Nursing from the 1980s to 2020s. I am going to be reflecting on key changes that I experienced in my nursing role as a registered nurse for the last 34 years that link to nurse leadership, service delivery, nurse education. And I'm one of the ageing demographic of nurses that people keep talking about in the media, and a third of my generation that trained in the 1970s and 80s will be retiring in the next 5 to 10 years. And with that goes all of that experience and knowledge and skills. And we were the last generation to remember nursing prior to business models being brought in the early 1990s and the purchaser provider split. So I hope you find these reflections interesting, and if you're from the 1970s or 80s, hopefully you'll have some memories come flooding back. So I'm going to talk about changes in nursing care delivery, nurse education and nurse leadership. I will bring in some key political papers and talk a little bit about NHS restructuring. But usually when nurse educators talk about this, like I used to in the past, we didn't bring in our past experiences necessarily. So hopefully it will give you some specific examples of how it differs. As early career nurses, or newly registered nurses, you're starting out in your careers, and it's important to reflect back on our nursing history and for you to have that knowledge to inform your future practice and to influence change in the future. So I hope you enjoy the reflections and this talk. Do check out my YouTube channel, Support and Career Development for Nurses. It's free to subscribe and there's a lot more videos on there, so hopefully you'll find those helpful too. So looking at nurse education and being a student, I had my training in School of Nursing, and training was focused on disease symptom management. The School of Nursing was always based in a hospital. There was no critical analysis or reflection whilst I was being trained. And I checked out my certificate, my nursing certificate, and it says level 1. So student nurses today, a degree, it's a academic degree. They're highly educated. Nursing is a safety critical profession. Very different to the 1980s, where we were there just to deliver care. We were seen as a pair of hands, and it was all about symptom management and condition-based care. I was paid a wage as a student nurse, and I was in the staffing numbers, whereas students nowadays are supernumerary, so they can visit spoke placements and they are not in the rota staffing numbers. We had block placements over the course of the programme, and we knew where we were going for the whole programme. So I would have community care, learning disability placement, child health, mental health. I was very sick on child health placement. I remember catching diarrhea and vomiting because my immune system was not up to speed. And we had no assignments on placement, whereas students nowadays will have OSCE exams. Whilst they're in placement, they're going to be have assignment works on 2 or 3 modules. They'll have dissertations the last year, so they have a lot more stress academically as students nowadays. We also had a clinical tutor that was a defined role to assess and sign us off for these key assessments. So we had a bed bath assessment where we met all the hygiene needs of a patient for the morning. We had an aseptic wound that had to be dressed and wound care to be signed off. We did the medications for a whole ward, and we had to know all the ins and outs of the medication side effects. And then we had to run a ward for our final placement. Whereas nowadays students are supported by practice supervisors who have their own caseload usually, and the quality of their supervision will be according to the staffing levels, I would say, potentially. So it's interesting to look at that clinical tutor role and whether we need to look at getting a clinical educator type role back to support students while our staffing levels are not as good as they should be, because we've got 40,000 plus vacancies in nursing at the moment, which does have an impact on placements. Looking at the changes that took place. So in 1989, we had Project 2000 launched by the UKCC, which was our regulatory body then. There was much more focus on community health, health promotion, rather than this disease management model. And universities were then contracted to deliver nurse education and secure placements with placement providers. So nowadays students will know about their placements less in advance than I did. I knew where I was going through for the whole of my programme. And now we also have this hybrid of pre-registration traditional nursing programmes and apprenticeship routes. And we have an apprenticeship levy. So some students choose to take an apprenticeship route where it's a paid role, and others will pay their own fees at university using the traditional route in England, that is, because the NHS bursary scheme was funded by Health Education England, but the burden of those fees now has been transferred over to students. And there is a maintenance grant and tuition fees, tuition loans, sorry, like other students, and this new student nurse grant. And obviously this changes over time, so it may change next year. For example, this talk is, for a disclaimer, this talk is May 2022. However, in Wales it's different. They support healthcare student fees as long as you work in Wales for 2 years after you've completed your course. And in Scotland as well, the fees are funded through their nursing and midwifery bursary scheme. And it all depends on your financial situation as to what you will be given as a student nurse. So, but with this nursing associate role, it's a 2-year foundation degree. This is different from the registered nurse degree. It's a standalone role that's registered with the Nursing and Midwifery Council in England, and it was announced in 2016 that they started to have these pilot sites, and it's done as usually as a degree, as a foundation degree apprenticeship. And then we have these top-up degrees and also level 6 nursing degree apprenticeships, but there isn't as many nursing degree apprenticeships. So there's a lot of discussion in nursing journals and in the nursing community about apprenticeships, and we've got this hybrid of these two routes. So it would be interesting for you to talk with module leads on how nurse education should be delivered in the future. And I'm being very careful to be neutral in this talk because I want you to discuss with your module leads rather than me giving my political or professional views. Nursing roles. So nursing roles job titles were standardised in the 1980s. So I only remember staff nurse, sister charge nurse, matron role, health visitor, district nurses. There wasn't all the specialist nurse roles and the educator research roles we have nowadays. I only remember there was a breast care role that was for patients that had mastectomies. There was a nurse that supported patients with colostomy bags, but otherwise I don't remember any specialist roles with my reflection. In 1990, Barbara Sitwell established the first advanced nursing practice course in the RCN Institute. She was a British nurse researcher and academic, and she brought this about because she was practicing in the UK and heard about these roles in America. So she networked and she was offered a scholarship to study in North Carolina in the US on a nurse practitioner advanced nursing practice course, and she brought back everything she knew, and she basically set up these roles and the training for the education for these roles. And it's really interesting. I did a talk recently, 5 ways to influence nursing practice, and that's exactly what she did. She networked, she educated herself, she went and researched, and she came back and then published and disseminated her work. So an amazing role model for nursing that changed the landscape of nursing roles. Another interesting paper is by Alison Leary et al. In 2017, and the reference is at the end of this talk. Variation in job titles within the nursing workforce. So when I talk about the 1980s and the standardisation of these set roles, very rigid, we now have this explosion in job titles for nurses. And in this paper, the authors examined variations in job titles of nurses working across specialisms. and authors found 595 different job titles, and it was amazing to me when I read this. And then another paper by Sprinks in 2015 entitled Call for Support and Standardising of Clinical Nurse Educator Roles found evidence of 35 variations of clinical nurse educator roles in the UK. These are really interesting papers that demonstrate the difference from what I experienced in the 1980s. So why do we have such a variation in nursing job titles and roles? And is this wide variety a good thing, or do we need more standardisation? So one reason I think is that managers have autonomy over their own budgets, and I'll talk about the change in leadership linked to the politics and restructuring where nurses are budget holders. And nurses now have ownership of their adverts. We have a less centralised approach. There's no national standardisation. But is that confusing to patients and to staff and to early career nurses? Or is this flexible? Is it allowing managers to create this fancy job title to attract people to a role? Or it could be an exciting new post that requires, that the manager feels it requires this new job title to meet the patients and service needs. So really interesting discussion could be had there, and also linked to dissertations. As long as managers link to the agenda for change pay scales, and they adhere to job descriptions and align to a banding, that the pay aligns to the banding, there is that flexibility with titles and to tweak job descriptions. So it'll be interesting to see what happens. And I know people like Alison Leary and others, and looking at professional forums and discussion boards in our nursing professional social media forums, there is a lot of discussion of standardising a specialist nurse role. It's usually set at a band 6, for example, working towards a master's, and an advanced nurse practitioner would be a band 7 or above, and would be have a master's, and whether that should be standardised, because sometimes roles may come out that are band 5 that are labelled as specialist nurse role. And do we need more standardisation? So interesting debate to be had. What was it like to practice in the 1980s linked to leadership? It was autocratic, hierarchical. I was a very timid student, and I was shouted at, berated all the time. You were always called by your surname. You were there to do the task that you were given. You were never questioning, and you were never taught to be a critical thinker like nurses are today. You literally had to stand to attention if a matron entered a room. And if there are any nurses from the 70s and 80s out there, they may remember these. This is my reflection. This is what I experienced. And uniforms were belts, buckles, hats, dresses. I couldn't fit my bun under my hat, so I was always getting told off. You had to have your hair off your collar, so you couldn't have a ponytail with your pony down. It had to be up in a bun. And if your uniform wasn't clean, you were sent home. Uniforms, you did not wash your uniform. You had to go down to the bowels of the hospital, and you were shoved this uniform by the lady in the uniform room, and you had to get changed every day, go and collect your uniform and get changed. And which differs very greatly nowadays, where employers, apart from if you work in theatres, for example, most employers, you basically have to wash your uniforms at home. And this came as a bit of a debate in nursing with COVID, for example, and people started to question whether we should go back to having these in-service washing facilities for nurses. We also started to develop in the early 1990s task allocation model of nursing. Prior to the early 1990s, we had this task allocation model of nursing, where you were assigned individual tasks. As I sort of alluded to, you might be told to go and empty all the catheters on a ward as a student nurse. So you didn't have this person-centred holistic care where you were given a caseload of patients. It was task-based routine care. You had to get your patients out of bed on a hospital ward from 6 to 7. They were fed breakfast, and they were then ready for washes at 8 o'clock. So that structured routine also went over to patient care, and there was less patient choice. So patients were more of a passive receiver of care, I would say, in the 1980s. We did damp dusting. So before you started anything, you had to go and damp dust and clean around a bedside area. And you had this rounding approach to care. We had what was called back rounds or comfort rounds, where we went round with a trolley to prevent pressure sores, and we turned patients, hydrated, offered food, and comforted patients to make them feel safe and made sure they were warm, for example. We made tea for consultants, so nurses were viewed as a handmaiden, and I very much remember that. And the only person really that went into the office, looked at notes and talked to consultants were the charge nurse or the nursing sister. We had no manual handling aids, so I was taught to do an Australian lift and I remember, and that lift is banned nowadays because we have hoists, so we're told not to, whereas I was trained to use that lift. And I remember lifting a 20-stone gentleman, I was only 8.5 stone, with this other nurse that was very petite, from a low down chair to a bed, and he was 20 stone, a big rugby player. So the load on my back, being so small framed then, not now, but then, would have been immense. And many nurses of my generation have bad backs, or I went into education in my early 30s due to that, because we had that strain on our backs with no hoists. We also did not administer intravenous drugs. That was a medical job to do. And I remember the debate about professional boundaries, and many nurses saying that we shouldn't be doing it, and there was another group that said we should be doing it. When IV administration first was given to nurses, it was only matrons that would do it. I remember being on shifts, on a night shift, and a matron came down. She was the only person who could do IVs, and she did every single IV across 4 wards. Again, this routine-based care. We had less documentation though, and administration. We only had activities of daily livings, nursing assessments, care plans, which were done at the bedside with the patient. You goal planned with your patient. There was no standardised care plans like we have nowadays. You had to write your care plans from scratch, and a lot of our nurse training was about having the knowledge to write those nursing care plans, to know what to do if a catheter blocked, or if somebody was pre-operative, for example. Fluid charts, diet charts and observation charts, they were all paper. So managers had less administration. There was no computers, there was no mobiles. So we didn't have the audits, risk assessments or target setting. Every treatment room looked exactly the same in the hospital. The equipment was the same. And that was due to the fact that nurses didn't have budget. So nowadays, a manager will have a budget, can buy in a hoist, and they can look at 3 or 4 different private companies. So a student going across a service or going across employers navigates different systems and different hoists, not just hoists, but different equipment, for example, because managers now have autonomy and they have their own budgets. We moved from a task allocation to team nursing and primary nursing models in the 90s, and we had this evidence base that started to emerge and in nursing practice. And I remember my first experience with evidence-based practice was a nursing sister who was having an argument with a consultant who prescribed a rubber ring, like literally a rubber ring, for a sacral sore on a patient. And before we knew any different, many areas would use rubber rings because we didn't have the mobility aids and the manual handling aids that we have nowadays. This came about due to research that happened. So sometimes patients with a sacral sore were put on this rubber ring, and evidence emerged that when you put a patient on a rubber ring, you will get a sore or red in a circle where the patient's sitting. So the sister started to argue and say, no, it got quite heated. It started as a discussion, and the doctor was adamant, no, I want you to put him on a rubber ring. So she went and got about 20 articles. I remember them in her hands piled up, and she said, watch me. And I went with her, and she put them on his desk. And the next day he came out and he said, point made, take him off the rubber ring. And so but that really shows the power dynamic changing. It stayed with me because it was almost like the power dynamic was changing, and it was changing due to research and to that evidence base. So it was just an interesting reflection to share, I think. And it links to my video on 5 ways to influence nursing practice, the power of research and of publications and of sharing your work. And if you don't share it by word, share it by mouth. You know, looking at podcasts and blogs, you know, for example, and joining forums and working groups and shared governance groups to influence practice. NHS restructuring. So I talked a little bit about it being more centralised, which it was in the 1980s. Prior to 1982, we had 90 health authorities, and then we moved to 192 district health authorities. The white paper in 1989, Working for Patients, is interesting to look at. With this paper, it first described reform to bring in the internal market into the NHS, and the reasons were to improve efficiency and to improve patient choice or patient responsiveness, I think was the term used at the time. And then we had the National Health Service and Community Care Act in 1990, where the purchaser-provider model was established. And the purchaser-provider model, it's essentially a service delivery model that relies on contracts, and it's managed by contracts. And this creates competition between providers who have to stay financially afloat. So we went from having much more longer term budgets, 10, 15-year budgets, to annual budgets and fiscal budgeting, as opposed to this more long-term planning. And hence that nurse leaders and managers nowadays have these budgets, these annual budgets that change. And I would say it causes more stress on the system and on people with annual budgets that change. You know, that makes sense. That there's more pressure on the system. And then prior to 1991, we had publicly funded hospitals based on local populations. Another key change was the creation of NHS trusts in 1996. So the regional health authorities were abolished, and another key paper, there's some in between, but this was a key paper, was from Andrew Lansley in 2012, and that's the Health and Social Care Act, because we then had the abolishment of primary care trusts and transference of funds to commissioning groups, partly run by GPs. So we had this increased competition again. And so you can see that there's been this continual fragmentation and layering within the NHS relating to market forces and these business models being brought in. And so from a perspective of a nurse, I would say it's the budget holding that's had the biggest change on nursing and on service delivery. And nurse leaders and managers nowadays will, as I said, will be budget holding. They will have £1 million budgets sometimes, with staffing and with environmental and equipment budgets. And leadership courses at master's level reflect that. So if you're looking at a senior leadership role, or a ward sister or charge nurse or community sister or charge nurse role, you would be looking at doing master's level courses and leadership courses that have modules such as finance, business management, service improvement projects, quality improvement projects, and all aligned to this business change, really, because it's reflected in nursing as well. So inevitably, with the changes, with the business model being brought into the NHS, nursing has reflected that, the restructuring of nursing and nursing roles. When I reflect back, we didn't have target setting, monitoring and auditing, which we have across the NHS. And those of you starting out your career, that's all you're going to know. More nursing roles now related to service delivery. We didn't have bed managing roles, floor coordinator roles, case manager roles in the community like we do now, because we're looking at trying to get the throughput through. And for NHS and community trusts to make money, they have to get their waiting list down and get a certain number of patients seen. So there's that pressure, more pressure on the system. We have clinical governance roles. You can get so if you have hospital acquired pressure ulcers, for example, that was looking at one of the targets that needed to be set. and you get an instant report. So you get a whole team of tissue viability created to prevent that risk and to prevent incidents. And nurses held their own budgets, as I mentioned. So talking to finance teams and asking managers about their budgets and the roles linked to safety, governance and so service improvement will be really interesting as students, and also to help you to look at potential careers in the future, which I didn't have those opportunities when I started out. So looking at jobs, vacancies and staffing, there was really high unemployment in the 1980s. There was over 3 million unemployed, which is approximately 12% of the population, whereas nowadays we've got approximately 4%, don't quote me on it, a lot less. And when I registered, I failed my nursing final, so I was the only one in the cohort to fail, which meant, and the lack of jobs in the UK was reflected also in nursing, and I had two chances to go, one job in London, one in Cambridge. So very different to the choice of jobs available nowadays. We've got over 40,000 plus nursing vacancies today, for example. So we've got a lot more career opportunities and jobs. The other side of that is, I don't need to tell you that having all these vacancies does, staffing impacts on the quality of care. It impacts on the quality of nurse placements and the support of junior staff. And there's a lot of work at the moment being done with recruitment. We're on a positive, we're seeing a lot more applications to nursing, but we do need to keep and retain our current workforce. So there are many professional bodies, the Nightingale Foundation, Royal College of Nursing, looking at early career support, but also we need to look at people that are experienced and trying to retain them in the role as well. Jane Ray is doing a really interesting project at the moment, and she's National Preceptorship Lead, developing a national preceptorship programme for newly registered nurses. This is a brilliant piece of work to look at standardising preceptorship and designing a programme for newly registered nurses. So some great work being done and some great topics for dissertations linked to nursing roles, staffing, retention and support. So finally, I thought I'd end with a patient case study relating to an ethical discussion that I reflected on in the 1980s because it has relevance for today. And I looked after a lady with motor neurone disease, and I stayed in neurosciences as my specialty, and I was early career nurse, and I looked after this lady. She was very young, she was in her early 30s, and her children would come in every day and sit on the end of the bed after school. And I remember going into the office and the consultant and senior registrar were having a discussion about whether she should have BiPAP, non-invasive ventilatory support. Nowadays, everybody with motor neurone disease would potentially be offered this, and they may choose to have it or not. And we have this wonderful Motor Neurone Disease Association. Back then, this was very new and neuroscience units were just starting to offer it. And the consultant was very much questioning it, saying, is it going to prolong her pain? The registrar was very much, no, we need to offer her the choice. And in the end, they decided to offer her the choice. And it was the right decision so she could keep seeing her children. And interestingly, she stayed on the ward until she passed away, because then patients weren't nursed so much in the community. So that's something interesting actually as well, that patients tended to stay on the ward much longer. And it made me think about ethical discussions today, because you're starting out in your careers and you are going to see massive changes linked to the ethical discussions linked to areas such as sharing patients' data. We have electronic patient records and whether patients have access to that data. Genetics. We have because I'm from a neuroscience background, we have lots of neurological illnesses, chronic illnesses, terminal, that cannot be treated. And there's lots of research going on in the future now to do with genetics and looking at some of these long-term illnesses and preventing them and seeing if we can turn off the gene that might trigger some illnesses and cancers and heart disease. And then the counter argument to genetics is that, and the ethical debates are around whether people should have the genetic coding and sequencing but genetic coding and knowing. So for example, you would know that you may be predisposed to a long-term illness, a terminal illness when you're young, when you're a child, for example. And we have that technology now for some long-term chronic illnesses. And would insurance companies get hold of this data? So you will see these sort of discussions in the future. And then we've got the use of artificial intelligence and robotics. And in the future, will nurses be replaced by robots? I know Elaine Strachan-Hall, there's a really good video on the Florence Foundation, Nightingale Foundation. She's a scholar and she's done a video on robotics in nursing, and it's a really interesting discussion. And in the future, will we potentially be chipped in our hands maybe, and have a little robot come when I'm old and grey, I'm grey now, but in a hospital bed in my 80s or 90s, and a little robot comes and I have an armband or press a code in and my medication comes out instead of a nurse, for example. We have no idea what's going to happen in the future, but we're going to be using AI and robotics in the future, and it will come into nursing in some form and in medicine. Well, it already is in medicine, in surgery, for example. And is that a good thing? Is that going to free nurses up to have more time with their patients, or will we become more detached from our patients, and will it cause a barrier to that therapeutic relationship and just be used to save money? So your staffing levels will be changed, will be lowered, because we've got these robots doing aspects of nursing work. So it would be fascinating to see what happens in the next 30 years and how I will be nursed in the future. So I hope you found the talk interesting, and you can have some discussions maybe on that topic or on the future of nurse education, leadership, specialist or advanced nursing roles with your module leads, and looking at future restructuring, that if we have another paper, we're bound to have more papers and more changes, that you do think about those changes. That we don't just passively sit there thinking, oh, you know, what does this mean? What is this going to mean for nursing? And that you educate yourself about nursing history and politics. So the references are for Leary and Sprinks there. And if you have any questions, do put them in the comments in YouTube. You can contact me on Twitter, DM me, or on my website or on Instagram. And I hope you have a good rest of your day or evening.